Hi, welcome to PBH 212. Again, just as a reminder that I do in the beginning of all my presentations, make sure that you've looked at your syllabus, check your due dates. The syllabus can change during the semester, so I usually don't change it, but there's been occasion where I've had to. Please make sure you look at it, because maybe the assignments have changed too, and that's part of your deliverables. So make sure that you're on time with your deliverables and you're on track. I also mentioned in my introduction video that I do not release the next week until about maybe towards the end of the first week is being completed because I want you to focus on that. This first week was a short week, so probably Friday you'll start seeing the second week up. But weeks after that will probably be on Fridays. You'll see the release of the next week, so you can start to read and do the work. Okay. So we're going to look at chapter 6 today, which is the information infrastructure to support public health. It's a very important chapter. So what are we going to cover? So first, we're going to look at how infrastructure and information architecture support the work of public health organizations. Then we're going to look at the 3 components of public health infrastructure. Then we're going to look at the 7 components of generalized health information architecture. And then we're going to look at the differences in infrastructure versus information architecture. And then we're going to look at the role of an informatician serves within a public health organization, and then informatics competencies required of various public health roles, which is very important. And then finally, identify trends affecting public health infrastructure, and what are those? All right. So let's look at information infrastructure again, the framework of 3 interconnected systems. So a capable, prepared public health infrastructure consists of a skilled public health workforce, a robust ICT, and an effective organization. So working together, people across several public health organizations can leverage the information to support health and well-being of communities, state, national, or regional. And collaboration is necessary to address those core functions. So the organizations we talked about are going to talk about now are government and non-government entities within the interrelationship that create, enforce policies to protect, monitor, and improve public health. Then there's the people component, right? So the people are the public health workforce. They contain both personnel and professional interrelationships within and between organizations. Some of these folks come from outside entities. Some come from their internal. They may collaborate with a lot of other people. And so you're going to have this crossover a lot. And then information and communications technologies, which is ICT, hardware, software, and devices that can capture, store, manage, exchange, and create data and information used by public health organizations and all of the people in the workforce. So there's been an evolution in public health infrastructure. In the beginning, the primary focus of public health was disease. So we were always trying to track new disease outbreaks, etc. But that slowly evolved from epidemic to looking more at chronic illness like asthma and high blood pressure, etc. Trying to understand more about how populations were being affected by this. And that kind of grew into the idea of social determinants on health, which we've discussed a little bit. And that also pointed out the need for many more flexible systems in the infrastructure. We were siloed a lot. How are we going to share all this stuff? Well, there's this great need is developing. And then out of that came the Affordable Care Act of 2010, which had its requirements of more available healthcare to all. And in support of that, the year before, the high-tech or the Health Information Technology for Economic and Clinical Health provisions of the American Recovery and Reinvestment Act provided funding for all of these new systems because they would have to be done at every level, district, province, national, and local, a town or city. So there was an evolutionary change in how data was being looked at here. it enabled population health informatics infrastructure actually to move from hunter-gatherer of data silos to agrarian cultivators. And what that really means is that everything we had for data up to this point was siloed, and that means it was on its own. You couldn't really just reach out and say, oh, give me an EHR data and I want to correlate that with health information networks, etc. They didn't exist, not like that. But with the advent of new infrastructures, now we can actually look at these as one large ecosystem together. So agencies no longer really control the entire information chain. Instead, they become collaborators and secondary users of data collected in typically for clinical purposes. So this idea of running out looking for data is really going away in public health into more of reportable, actionable data. There's already ways to get some of this. It's just a matter of how available it was to the public health area. And that's really what's the big change here. So historically, again, public health agencies had created and maintained information silos. An example of this was HIV/AIDS registries and treatments in the immunization registry, environmental monitoring. There was all very separate systems. You needed special permissions. They might even work in different languages, meaning computer languages or structures that didn't talk to each other. So we had difficulty for program areas to share information. Suppose I wanted to do a comparison between the immunization registry and AIDS or environment. I'm trying to do a correlation study. Well, guess what? I can't. Not with a lot of difficulty. It was really hard to do it. Reports were still more paper. It was incredibly hard to do. So we had the data, but we didn't have any way to get to it. So the other thing too that comes with this is every time you create a silo of data, you increase the support cost for this. So it was actually costing health agencies more to do this. It was kind of counterintuitive. So increasingly moving into the cloud, which we'll talk a little bit about, really changed how processing and storage could be maintained at a relatively low expense. So public health informatics recommended standards of approaches for collecting data once and using it for multiple business processes across the communication technology. So really, if you think about it, that's one of the things that informatics really has helped with, and that is how do you move data around? How do you share it? How do we bridge a lot of this? And so your book is a pretty good example. This is actually an example of how data would be sent to a dashboard. So we've seen dashboards before. We haven't obviously spoken about them in classes, but I'll tell you that if you go to any, even on television now, when you look at data, you'll see a lot of graphs that actively move that are very simplistic that you don't have to really, you can look at them at a glance and you really can tell what's going on with that data in that form. And that's what a dashboard really is. It should be very simple. And so if you look at this, what's behind it are a lot of different systems. There's a patient portal up here, right? There's a computer system that monitors that. There's a computer system that retrieves data from the electronic health record, right? These are adherence responses in this case that they're looking for diabetes. There's another app server that moves that data back over here. There's a patient selection, which is a study foci, which has to be controlled somewhere. There's outputs to a web service, and then there's a media hub service that moves things back and forth, and they receive different calculations from different places. And then you take all this information and through all these systems and put it onto a dashboard through another component, right? Another piece of software. And that gives you this view. And then the clinician is able to glance at that dashboard and glean a lot of information. Dashboards are very useful in any computer system, information handling system. And that really has to do with at a glance. So I can look at this at a glance and see, oh, it's green, I'm okay. Oh, it's yellow, something's going on. I might want to look into that. Red, I need immediate action. So just to say red light, green, green, yellow, red lights, you know that. from real life. So that's kind of how these things work and what we need, because it makes it so that I don't drown from this perspective in information when I don't need to. This over here helps me understand that. This is also part of the concept of clinical decision support, which we'll talk about eventually too. But this is a way to use data to help a clinician or anyone else who's the receiver of this information, could be the public, true, right, or group, act or respond to what's going on here. This also has to do with machine learning and AI, which we did discuss a little bit. So what's the difference between information architecture and enterprise architecture? Because there's a difference. So enterprise architecture is at the higher levels of an agency. It's used to organize data, information, and the communication systems that we use to move data around. Whereas the information architecture provides the blueprint for, let's say, an immunization information system that's used within a single division. So the blueprints need to obviously align with the enterprise architecture, but they also need to align with all the other information systems that are developed in the house that go together, or outside information that needs to be exchanged. So the EA will provide the blueprint for how various ICTs systems such as laboratory, right, syndromic and case-based surveillance systems connect or interoperate to support across the agency. So that makes sense, right? So you're trying to basically set a standard and a framework on how all of these systems will communicate and how the data will be handled so everyone who needs it can get at it. Or in the future, you need to grow or expand that. The blueprint will also allow for that as well. So information architecture unlocks potential because there's a lot of data out there. Obviously, we talked about that. So it not only would allow public health organizations to better connect with information systems in use within public health, but it also lets them look outside of the traditional systems of public health. We alluded to population health as one. So that begot the formation of information exchanges, which I mentioned before. They're very important. These are like hubs that allow disparate systems, different kinds of systems, to talk to each other through the use of another products called middleware. There's other ways to do it, but it's a simple, transparent way to move data around without you having to do anything. And that can be set up in different standards. And one way to do this is in the cloud. It's very effective there. And we'll talk about that here. So how would this infrastructure support public health functions in a community? So let's talk about surveillance of chronic disease. So many jurisdictions, they have laws that require the reporting of communicable or infectious disease. I live in one of those states. So how do you normally get that data? So the CDC uses behavioral risk factor surveillance system to collect data. So prevalences are available at the state and country levels, but local health departments are challenged. This is a space that's very difficult for them to reach into here because this is based in a cloud system. These two entities may have some architectural setup for that, but the local health departments don't. So this is really hard for them. It's almost like they have to reach out to them to get it, and then how do they get it? They're not going to have time to change the data. It's going to probably be paper, which is really not a good way to work. So integrating electronic health records from hospitals or physician practices with data, right, with using this surveillance system could help the local health departments better track disease. So if there was integration with this outside EHR in reporting straight into the local health department, it would absolutely help them. If they have somebody in their local community who has a disease that needs to be monitored, they're going to know about it instantly, even before the patient the hospital reaches out to them to contact them. If it's like TB or something and they have to be sort of like house isolated for some time, if they're able to do that, that really needs to be known, right? And it's the law. They have to be compliant. So a robust information architecture for public health can enable better tracking of chronic disease and evaluation of the public health interventions, which is another important factor. So we know about something, we institute an intervention. How do we know it works? How do we know how well we've progressed? You need that information in order to know that, correct? So how do you get it? This is how you do it. If you have a robust system, it will be able to reach out to look for trends or reporting data from a lot of different sources. So how would an AI support public health functions in the community so it can respond to the community needs? So one way it can, a good example is in 2017, the Department of Health and Human Services declared a public health emergency because of the epidemic of opiate-related overdoses, and I talked about that with you already. So from 1999 to 2017, more than 700,000 people died from drug overdoses, 6 times higher than in 1999, 68% more than 70,000 drug overdose deaths involved in opioid in 2017. That's a dramatic jump in anyone's language. So an estimated 130 Americans were dying every day from opioid overdose. That's how bad this was. That's why it became such a crisis. I mean, it was overwhelming hospitals. There was an instance in the last, I think just before the COVID crisis hit, where Yale New Haven Hospital was hit with repeated readmissions from the same people on the same day, hours apart, from opioids. It was a contaminated group that they got, and they were right back in the hospital. They would discharge them, and they'd go back and get high again, and they were right back in the door, and they could have died. And it came over, they were overwhelmed with the number of people. So can you just imagine if you spread that out over all the cities? It was a huge, it still is. So how was another way to respond to community needs with this? So another way is poison control centers. So local health departments have exploring ways to connect their infrastructure to sources outside their organization. So how do they do that? So one of the ways that has been cited in our work, in our book, has been this idea of being able to share data across a number of spaces. So how do you do that? Well, in this particular thing, um, a, a robust AI, might depict how information could be controlled, be connected between centers through the public health department. So this is a little different. So wouldn't it be cool if the public health department was able to deliver poison control center information to emergency medical services and public health information services so people could share this and they can analyze data all the time? So that's really the key to this. It can work in both directions, and it's really awesome when you think about it like that. So it's not just information coming into public health, it's information going out. And that's also part of what public health needs to do, right? Alert the public and protect the public safety. Okay, so a public health information architecture must capture information about individuals, right? And so who received public or private health services? We need to know. Who was that? We do need to trace that. Who provided those services? Where did they get them? Did they work? Where were the health services received? Were they in what town? What municipality? Were they in the same populations where that person lived? What care was provided? That also needs to be in there. So those models look something like this. So you have an open component layer, which has business domain services, which you need to have in any organization. So it could be management info, shared health record, health management information system that runs it. There's registry services, right? There's client registries, facility registries, health worker registry, product registries. All those things can be run through what's called an interoperability layer. And those allow different functions: authentication, interlinking, mapping between the databases, and it lets you get that information out to a point of service or back. And it could be mobile health system, which we'll talk about, electronic health medical record, which is important. It's a big area of data. Health information system might be a dashboard. might be a national alert system, a lab system that can feed in and out of this, in and back out a different way, pharmacy systems, and logistic management information systems. So this is really an interesting way to look at this. Having an open architecture really does help in designing really effective systems and legacy systems. It helps work with older systems as well. And this is just another slide. I made a bigger one just so you can sort of see it. But this is a new book, so you can look at it at your leisure. So as long as the repositories are exposed through this interoperability layer and services, an infinite number of options are available for deployment. Think about all the different connections you can make through these spaces. It's pretty big and a lot of different types. So exists multiple technical solutions for supporting public health, right, in an architecture. So cloud computing is one way to do it. And so historically, before there were cloud computing, the way it worked is we used large mainframe computers. We used to call them big iron, and they were centralized. And so in the era of the beginning of health, when computers came into it, this was the only way we knew how to do it. So most companies had gigantic computer farms. They were very large systems. You've seen them probably on some movies where it shows this great big computer box and lots of lights blinking on the front of it, or tape drives zipping in and out. There was a lot of different media forms at that point to process data. And basically, the only way to maintain that was in one center. So it was very difficult to replicate that. It was very expensive too, right? So one of the cool things that happened is eventually we started figuring out, well, what if we start to deploy multiple physical servers? We could have more than one of these in a smaller venue. And that's what started happening as computers got shrank. You started to get server farms, and those could be localized in an office or a building. You could have multiple ones that were tied together. And then virtualization really has been the last big step in this, and that really started 10 years ago, believe it or not. But that's the cloud, and virtualization is the representation of physical machine or software application in software. There's no real thing. It just looks like it. And cloud computing, again, it's a decade-old technology that scales up this concept of virtualization because it makes it really easy to use. And as of now, most organizations have moved into cloud-based structures, and we'll talk a little bit more about that. So cloud computing, it's a collection of computers that operate remotely. They use the internet. They appear to be a single system, even though they can be in completely different places. I mean, literally many miles apart. We can share resources like cycles on memory on really high-speed computers or with one another. And you can have virtual applications that run smooth, even though the computers are on the other side of the country or the world. I mean, there's a lot of companies that actually grew out of this idea. Amazon, which has their Amazon Web Services. Most people might equate Amazon as the place where you buy things, but really Amazon makes all its income really off of AWS, which is this enormous network of computers that are cloud-based. And that's how they run their model of operation, and they sell those services out to many, many corporations and healthcare organizations as well. Microsoft does it. There's a number of Dell. They're all in it. So there's some, I think AWS is the biggest right now, but there's a number of them that do this. But the idea here is you can scale up anything you want through a cloud and not have to own it. So I don't need to own the hardware maybe I need some really intensive algorithm run and I only need to run it for like an hour. Well, I don't need to own it. I can just pay for the time. I don't need to own it, and I can do it under contract. So it really makes this so much easier to do. And it also opens up that type of technology to companies who normally could never have afforded it. So it's a win-win for a lot of people. And it's also very inexpensive compared to owning your own stuff. So there's multiple options for public health to use cloud support to support all or some of its technical infrastructure. You can still have locally hosted and have some cloud involved, and you can use infrastructure as service. So that's one way. So that's called IaaS, and then there's PaaS, that's platform as a service or software as a service. And let me show you how it compares on this chart, which is from your book. So really, these are all concepts that have come from this idea of virtual or cloud-based computing. So if you do locally hosted, what you're saying is you do all your applications and data locally. Your operating system works locally. You have middleware that goes in between bigger networks and servers and storage that reinterprets the data so that this system can see it and it can work in those systems when you need it. But you handle and are responsible for all that. This is a big cost. There are some systems that need to be like this. And so they are. They are physically not connected to the web. They sit alone. And they do that for security systems. Sometimes in the military, that's this way. In some corporations, they still have locally hosted, separated systems that they might keep information on that they're very concerned about. But that doesn't mean that it can't be supported in the web. It just is the way that they view it. Don't get me wrong. Everything that happens in the cloud is super secure. It is probably more secure than this. Infrastructure as a service. This actually takes away the idea of this component, which is network servers and storage. You really don't need any of that. You can have that all virtual. If you buy a website online just to have your own website, or you see them, normally they're all running virtual. You're only connecting through your virtual portal to do anything to it. It's all existing here, which brings us to the platform. So now the operating service, which is the software component that runs all of this outside of that, is now also in the cloud. So that actually can be any operating system, or you can have multiple operating systems that run together through middleware that's controlled by those services you buy, that works well, that you don't have to worry about downtime, there's redundancy, all the things that you have to take care of here with lots of people and lots of redundancy, you're doing here without even thinking about it in here too. And then you can move over completely as software as a service. So this has to do with, and most of you do this and maybe not even know it, but if you own a Microsoft product right now, you don't really own it locally, you own it in the cloud. You may think you're launching it from your desktop, but you're only launching the kernel for it. The rest of it's up here. So really how this works is that this works really well in healthcare, but it works really good in the industry because it makes it so that you can't really steal software. It's gone now. It resides somewhere else, so there's nothing to copy. I mean, for years people used to do that. And that was a big security concern, right? How do you know people get updates and stuff like that? And that's part of this as well. All of this is up to date. You don't have to worry about any of those things. This is all being handled here. But the beauty is because there's all you need is an internet connection, it takes away all these specialized actual physical connections that need to be made and OSs and applications. It really becomes one very transparent system, which is what you want. Because really, you don't want to own this. This isn't the job of public health. Public health is to protect the public, not run systems. And that really kind of lifted this away and made it much more convenient for one to use. So robust information system, one of the things is immunization information system. There's also laboratory reporting. And then there's electronic case reporting and bidirectional communication. And so let's look at these. So immunization information systems has some main functions. It consolidates the immunization data from different sources into one. It pulls it together. And it provides patient-specific vaccine forecasting and decision support based on known immunization history and patient age. So this helps the public health department know if people got vaccinated, what populations are being vaccinated, and what geographic areas they're being vaccinated. And it also can be used to create reminders and recall notices also. So if I know you've gotten a vaccine or a medication, I can actually send out a recall through this service, which is awesome. You think about it. And it supports proper vaccine inventory management. So if I know that 80% of my population needs vaccines, I have to ramp up that part. But if I start to get if I get higher and higher rates of vaccination, then I make sure my vaccinations, I can lower my inventory. Also, geographically, if I think this one area over here is higher vaccination rate than this one, then maybe I physically need to have vaccine in this area to make sure that they can be more compliant. It could be that, right? And that happened during COVID. There were many areas that didn't have enough vaccine, as you recall, and it was where you lived and where the vaccine was being shipped and how it had to get stored. All this logistics had to be worked out. And all of that is handled through this kind of a system. And it allows to generate greater coverage assessments. So we can really look in real time. The feedback from all of this tells us where those people are, what group they're in. Is it a vulnerable population that needs us to do something more? Is it the elderly? Is it in a population that doesn't believe in vaccine? How can we do it? Do we need to go into that community and help them directly? We did that. I did that in Hartford, and it works really well. That's what you need to do. So laboratory reporting. So this is important. This is also required by CMS meaningful use. So part of this is part of promoting interoperability between systems had to do with laboratory reporting. It was very useful for all parties to know when somebody had an infectious disease or not, or if we saw the outbreak of something like SARS or West Nile virus or any of those things. We needed better reporting so we could find that out. So disease reports arrive much faster because of this. Improved reporting rates are the portion of disease rates that are reported to the public health department. There's one thing I should mention here, and that is that the laboratories themselves did not benefit from meaningful use funding. Most of them had to do this with their own money, even though because they were required by law to be interoperable. So some of the private labs that do the kind of blood work, you might go get a test or something, had to build all these systems to work with public health. So they work closely together, but they really did pay for themselves. This was not covered in here at all, which is a whole other issue. Electronic case reporting. So in stage 3, which is the last one of meaningful use, as well as the 2019 Promoting Interoperability Program, CMS wanted to have this as case reporting for measures for hospitals. They really wanted to know what hospitals were doing. They wanted to have public reportable metrics so that they could say, yep, here's the value add, here's what they're doing better, here's where the money goes, so we can say, yep, this is the right practice. Yes, we are paying for value. Yes, we're not wasting your funds, or we're putting funds where we need to help the public. So the method for reporting a case of infectious disease to a public health authority was sent from physician practices or hospitals. And Digital Bridge Initiative made this possible. So it just moved this data right over so that everybody could see it and share it, right? And this could include a case management system as well, which is really important, right? I mean, what if you needed to alert somebody who does case management for high-risk patients? Hey, there's a new high-risk patient. You don't want to lose them in this volume of data. And that's part of what makes this so cool. Okay. So bidirectional communication. So monitor disease and information in the community on events involving the spread of disease. So this can do things like public health alerts used to raise clinicians' index of suspicion for a known or unidentified disease. Commonly, clinical infrastructure outside the EHR to deliver guidance and information on vaccine supply management. So you get these public health alerts I'm talking about. Health statistics, which are really important. These are also doing supporting healthcare organizations, increasing responsibilities for patient population management, because we're making the statistics and research results more available. And that's really what's important. So we're sharing. So all the people, all our stakeholders, remember, everybody can see these now. And that's important. And then perfect person-specific case data. That's really important, because when you're really down into that space, you want to make sure you coordinate the care between the clinical and the public health departments for those specific cases that need to be managed outside of the tertiary system. Okay. Public health organizations need to manage public health infrastructure. So you need to create, enforce policies. By organizing work, public health organizations define business processes that drive public health infrastructure. By managing people, public health organizations define how and when workforces can access and use public health information. Very important. So management of public health infrastructure will require organizations to understand their business processes and needs of public health workers. So in order to do this, you really need to know all this. How else would you know what people need information and when they need it? So a clear understanding of processes are needed. So in the context of public health, a business process is intended to support the needs of the health agency, community, or target population. So documentation, business processes, and redesigning them to meet the challenges using business process analysis, BPA. Informatics and analytics does this. It's been done in industry for many, many years, and usually comes from experts in those fields that understand the information systems that needed to be pulled on. So there's a shift in doing this from acute to chronic disease surveillance, because really, what do we really want to focus on? This. Chronic disease helps us understand how to better manage resources so we don't get to the acute stage. So we really want to be here. This is really a shift. We want to see that. And we want to increase the flow of electronic data from clinical health. So we're getting a lot more clinical data out into the public health department faster so that we can analyze it and look at it and say, there's an awful lot of admissions suddenly for this in the Hartford area. I wonder what's going on over there. And we can start to look at that and understand it. We can also use it for things we know about to help us see, is there a trend down? So that's kind of why we want to know that, right? So public health want to understand end users. That's important too, right? So if you're talking about people that work in public health, you need to be involved in that. So you ask and involve users. They need to be in the design, development, and implementation of infrastructure. It is so important to have the people who are the end users of what you're going to do or designing be involved in this. Informatics is a huge bridge for that in all areas. So in the clinical area, it's bridging nurses, physicians, respiratory therapists into let's design a better healthcare record. They need to be part of this. They're going to use it. And we need to understand that business model in order to do that. So people who usually work in that space are from clinical side of the house. Nurses, doctors, pharmacists become informaticists because they understand the work, and they also help with the technology part. In public health, it's going to be public health professionals who are going to be more towards the informatics area. That does not negate IT, which is also important in this as well, but you need to have those users in the end directly involved, whether they be, with informaticists or not. They've got to be included in that conversation. So early and frequent involvement of frontline public health workers is important. We'll call them users. So when you design a system or process, users should be asked about needs, and they should also be shown how it's going to work, which is part of this usability testing. It's performed where end users attempt to complete certain tasks using what you have designed. So you put that together as a workflow. They try to use it, and they'll tell you, this works great, or I don't like this, or how do I find that? Sometimes it's a matter of change acceptance, but a lot of times it's because we didn't listen enough, or we need to make a change. So we go back, cycle through, make a change, represent. And there are people that are the third component to public health infrastructure. So organizations need to train and prepare for 4 types of public health workers, correct? We have end users. So what do we have? We have executives. Those are the state health officials, the county officials, the branch chiefs, and the others who lead public health organizations, the managers and the individuals who direct or coordinate public health programs. Those are important, right? And then we have the managers, I mentioned the managers who coordinate the programs, the end users. So those could be like the epidemiologists who communicate disease to nurses, to food safety inspectors, and others are the frontline public health who interact with the information system. So we have to take those people into account. And those workers need to train on the systems, right, before they can use them. And then they need um, to conduct the business of public health once they understand them. Then there's the informaticians, and we really are those specialists who support the healthcare, public health organizations design, manage, and in the evolution of information and work processes. We often interact, I mean, often meaning all the time. I'm not going to say often, we interact a lot with any of the people we support. If in the public health area, it's the public health workers, any of these, always even ourselves. And that means observing how they use systems, getting feedback from them, trying to find better solutions. They may have ideas. How do we help them make those ideas a reality? How can executives move data down, or how can end users move data up to them? It really is part of what we do. We help guide them. So development of information architecture for their organization, that's part of what we do. Implementation of new communication, technology communication that meets the needs of the end user, maybe something that's been bought by another company, from another company. We do reviews with vendors. We look at front systems. We see, is it make more sense for us to make our own stuff, or does it make more sense for us to buy it? In the public health area, it's probably going to be a purchase or some kind of a contractual agreement, because you don't really have those kind of resources. Collaborate and work with partners to realize the interoperability of robust public health information systems. And that could be working with hospitals or frontline staff or government systems or other types of systems to figure out how do we get that information into our place, and how do we get our stuff out into them. The recognition of the Chief Public Health Informatics Officer is pretty new. The CDC actually has one now, which is great. And they have rolled out into some of the other larger healthcare communities or states. So they're around. There's a need to train additional public health workers into informatician roles. As I said, the best informaticians come from the end of the doing, so the sharp end of the stick. If you want to teach informatics, or you want to be an informatician for a pharmacy, the best candidate is a pharmacist or someone in that role who can learn the technical side of IT and also the methodology of developing and studying data and doing those kinds of research positions. And that's where you get those people from. So it's really important that we think of this like folks that are in public health who want to move into the informatician role. There's a great need here, but there's not a lot of resources to support it. So I just want to say that before I start showing you some numbers. So 1% of the U.S. public health workforce includes individuals who have an informatics role, and I'm one of them. At the state level, it's about 1.1%, but at the local level, it's less than 0.3%. So most local entities don't have any type of informatician role at all. It usually comes from the state, or maybe if it's a really large municipality like a city, they might support an informatician. Usually you find you are in that role one to many, 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 many users. I can tell you that at Yale New Haven, when I worked there on the clinical side, clinical informaticians, there were 3 of us to support that entire organization, that hospital. And we're talking the largest hospital in the country. Yale New Haven has over 1,500 beds. It's a gigantic facility. So just think about that. So it's a very small percentage to the number of, and there's other ancillary things that go along with that. So, but that's changing. So growing need for public health informatics competencies will require schools of public health. So you're in one right now. Even at this level, it's really to identify the sources of data and information to access health of a community and collect valid data for use in decision making. We're trying to make everyone more aware of that, what is involved in this. And that's part of what this class is about. Creating informatics concentrations or specializations within epidemiology degree programs. If you move on into a public health arena and you move into, or you move into clinical or one of those other areas, there are specialized programs for informatics in those arenas, or certificates or organizations. They do require the education background and the time in the position in order to get those certifications. So it takes a while. It's just as hard as, I would say, making a specialty within a particular program. So, but it's worth it. It's hard work, but it's worth doing. And collaboration with schools of information computing or informatics to offer joint majors or minors in public health informatics. So minors being you might already hold a degree in a particular discipline like nursing or healthcare of some sort, and you want to come into healthcare, if you want to come into informatics, you can do a minor. So in the public health arena, same thing. If you get a degree in public health, you can actually probably apply to universities to get a minor in public health informatics, which will allow you to leverage that in your position because you'll get a better understanding of what's going on. So, excuse me. So there's some real world there's instances of robust information systems supporting public health processes, and your book cites Indiana Network. It's a really big one. It's been around for a long time, and so it really talks a lot about that. So the primary use is to improve communication and decision making in the context of individual care. So how do they do that? So it includes public health reporting and syndromic surveillance, meaning that you can actually look at, let's say, a laboratory result. So I get a lab result back. In this system, not only do I get the result back and it goes to where the information originated or the order came from, but public health gets an alert for this to help. It can identify elevated lead levels in blood if that was what they were looking for. There's parameters on these. So when they have certain tests, they get an automatic alert and a value right to them. They don't even have to ask. It just happens, right? Research, it extracts the address for, let's say, that patient with the lead level and integrates that information in geographic locational work. So if I start to see a lot of high lead in a certain area, of course, what does that mean? We need to look there. Are we dealing with a lot of old buildings, lead paint issues? What do we need to do to remedy that? And that's kind of what happens in a lot of other health departments around the world. They usually partner with local and state health departments to facilitate access to data because you really want to, in all venues of healthcare, support each other. It's the outcome of that patient that we're concerned about. So how do you do it? It's not just in the tertiary mode, it's in the public health mode. So moving that information around helps a lot of people. All right. And so we need to make sure we're transparent and use it well. So again, in that system, you had patient care, public health, and research, and you had a laboratory result. What would happen is automatically you are delivered that information right to you. You don't have to ask for it. So it might be that the patient care facility over the patient was somewhere that had a blood test ordered. It might be routine. It might have been because in the patient care arena it was ordered. That information is filtered and sent to the appropriate parts of different organizations when they need to have it. So it really makes sense, right? I mean, the research department might not need all this data. They might need a piece of it. The public health department wants to know about lead levels being elevated. They also want to know where is that happening. So they need that information. So we don't want to information overload anyone, nor do we want to restrict the information. But you can build in filters so that once the information is delivered to you, you only have to look at the parts you want to look at. If you want to dig into it, you can. But that helps get the information where it needs to go fast. So let's just summarize. So the model of an ICT architecture, information systems that support effective public health practice, key informatics factors for managing organizations, important informatics aspects of the workforce, public health infrastructure. It's complex, it's evolving. And public health infrastructure will change as health reform is implemented. It has changed considerably. It will continue to change as that is sort of a political football, so it's sort of a back and forth, but it is moving into this more of aggregarial type of view of data, not this, hunter kind of looking at it. And informaticians seek to design, implement, and evaluate and evolve those information systems across public health infrastructure. That's really part of what's going on in that venue, and that will always change, always happen. You get to a point, but there's always something else, and you want to move things around. But it's getting to the beginning of it right now that's the biggest lift. We're still in the middle of working on exchanges. Connecticut's health information exchange is called Connie. It was just introduced in February of this year, so it's very new. There's still things being worked out in there, but that's the very first large state healthcare initiative to try to pull a lot of this together and share data. And hopefully now that once that's been established, it'll only get better. So that's the good thing about this. So future directions in this are going to be intelligent public health systems, things that bring information to a user in time when they need to see it. So people that work in public health or other related systems generate data. It gets to that right individual when they need to look at it, whether it be the clinician, public health care worker in some form, or policy advisor. They get to see that data when they need it. The other thing is interoperability. Very, very important to the success of any data system is interoperability. The cloud has really stepped that up, so we don't have to think too much about that as much as we did. There's still a lot of work to be done in data structures and that kind of thing, so that's not going to go away, and it's always going to be part of this, but it's just the idea that we have a place to do it now, and that's really cool, and it will always get bigger. Infrastructure investment, and that's the other thing. We still need some infrastructure. It's not going to go away, and it doesn't necessarily mean people. It's systems, and I shouldn't say just systems. It's people too. So it's informaticians and researchers collaborating, and frontline staff collaborating, and others outside of public health to help actually support it. And what systems can we kind of use that are not ours, but we can still get data out of them from the public health perspective. And that is it for this chapter. Thank you for listening.